What could be referred to as dizziness by the patient? Rotational vertigo, sense of instability, ataxia of gait, disturbance of vision, loss of contact with surrounding, nausea, loss of memory, loss of confidence, epileptic convulsion, development of vertigo, CNS, the afferent visual proprioceptive vestibular dizziness, oculomotor skeletal muscle vegetative. What should be considered dizziness by medical person? Vertigo, a sense of feeling the environment moving when it doesn't, persist in all position, aggravated by head movement, disequilibrium, a feeling of the unsteadiness or insecurity without rotation, standing and walking are difficult, light-headedness, swimming, floating, giddy, or swaying sensation in the head or in the room. Question to be asked taking the history. Anamnesis, what is the patient means by vertigo, time of onset, temporal pattern, associated sign and symptoms, tinnitus, hearing loss, headache, double vision, numbness, difficulty of swallowing, precipitating, aggravating, and relieving factor, if a episodic sequence of event, activity at onset, ARIA, severity, amnesis, examination of physician, patient with vertigo, physical exam, spontaneous nystagmus, positional nystagmus, opostigmatic nystagmus, posture and balance control, Romberg test, blind walking, Antenberger, Barian's test, stimulations of Laprinus, caloric test, cold and warm water, rotational test. In case of vertigo, non-spontaneous nystagmus, posture and balance control negative. There is nausea and vomiting, sweating and tachycardia, posture and balance control positive, nausea, vomiting, swelling and anxiety. Internal medicine, cardiology, psychiatry, harmonic vestibular system, loss of hearing, tinnitus, vestibular neuronitis, Meniere disease, otology, numbness and double vision, brainstem neurology. Here the specialist will need to take consultation. Differentiating peripheral and central vestibular lesion, peripheral harmonic vestibular syndrome fall in Romberg position and deviate during walking, which close eyes to the side of the slow component of nystagmus. Direction of nystagmus doesn't change with direction of gaze. Nystagmus can be horizontal, rotational, but never vertical. Nystagmus occur after a brief latent period. Severe rotation, warning vertigo, symptoms aggravate after moving of the head position. Severe vegetative signs, vomiting and sweating, fear of death in severe cases, caloric response decreased on site lesion. Differentiating peripheral and central vestibular lesion. Central, this harmonic vestibular syndrome, rarely harmonic, fall in Romberg position and deviate during walking with closed eye to the side of the first component of nystagmus. Direction of nystagmus might change with direction of gaze. If nystagmus is vertical or dissociated, it can't be peripheral. Vertigo is usually not whirling. Vegetative signs are less severe, if any. Associated neurological signs, diplopia, dysarthria, dysphagia, numbness, paresis, ataxia. Examination of patient with vertigo, laboratory examination and imaging, electrolystigmography, video oculography, audiometry, BEEB, CT, MRI. Common causes of vertigo: peripheral, physiological motion sickness, benign paroxysmal positional vertigo, vestibular neuritis, labyrinthitis, Monier disease, pre-lymph fistula, central brainstem, infarct, posterior fossa throat tumors, multiple sclerosis, syringulopia, Arnold-Chiari deformity, temporal lobar epilepsy, basilar migraine, other cardiac, psychogen, toxin, medication, anemia, hypotension. Duration of vertigo: the time and the peripheral or central, maybe second, BPV, and central, PB, aura of epilepsy, minutes, perilymph fistula, or VBTIA, aura of migraines, half hour, Meniere disease, basilar migraines in central, days, vestibular neuritis, labyrinthitis, VB stroke, week or months, acoustic neuronoma, drug toxicity, multiple sclerosis, cerebellar degeneration. Peripheral type of vertigo: benign paroxysmal positional vertigo, most often lost less than 30 seconds, occur only with change in head position. Nystagmus is transient, fatigable, and its direction is constant. Reason: otoconia. Positional vertigo is not always benign and not always vestibular in origin. The left and the right, and here we can see the position. BPV diagnosis: Dix Halbeck maneuver. We put the patient on a table and try to reposition his head in other direction. Medication if necessary. This BPV therapy. Positioning, change the position of the patient and train the patient to change his position. Vestibular neuritis: sudden severe vertigo, harmonic vestibular syndrome, no cochlear symptoms, tinnitus or hearing loss, reduced caloric reaction on affected site, recurrent attack, lost for several days. Reason: viral infection, vascular or unknown origin therapy, 1 to 2 3 days bed rest, vestibular suppressant, diazepam, colnizepam, antiemetic, vitamin B, antiviral agent, corticosteroid, labyrinthitis as vestibular neuritis, but there are also cochlear symptoms. Meniere disease: recurrent attack in clusters, tinnitus, progressive hearing loss, unilateral first, vertigo for at least 5 to 30 minutes, vegetative signs, sense of pressure in the ear, distortion of sound, sensitivity to noises, recurrent attack in cluster, tinnitus, progressive hearing loss, unilateral first, vertigo for at least 5 to 30 minutes, vegetative signs, sense of pressure in the ear, distortion of sounds, sensitivity to noise. Pathogenesis: endolymphatic hydrops therapy, salt-free diet, nicotinic alcohol withdrawal, acetozylamide, beta-histine. Pre-lymphatic fistula, fistula of the round window, hearing loss with or without vertigo, sudden changes of pressure in the middle ear, weight lifting, diving, nose blowing. Drug toxicity: aminoglycoside antibiotic, anticonvulsant, salicylate, alcohol, sedative, antihistamines, antidepressant. Other causes of vertigo: cervical spondylosis, sensory deprivative neuropathy, visual impairment, anemia, hypoglycemia, orthostatic hypotension, hyperventilation,